Welcome everyone to our monthly Health System Performance Network OHT webinar. This month we're talking ideas and measures on focus populations. Please, as you come in, let us know who you are by introducing yourself, your name and your OHT or other organization using the chat. Please do this. Ensure you click it up to say all panelists and attendees. This is really important for the other attendees today to be able to see who's here. Oops. Thanks for the person who just let me know that I was muted, because I did not mean for that. So I've been reading out David Black, you've been reading and seeing Lisa Campbell from osteoporosis, Laurel Horde, and you've been seeing the names come up from everybody signing in. We have almost 300 people online now. Welcome everyone, and just a big reminder to everybody today to make sure you move that box when you want to chat to all panelists and attendees. We spent a lot of time chasing people last month back and forth, so hopefully we won't be doing that this time. I'm speaking to you today from the University of Toronto, and the land on which the University of Toronto operates for thousands of years has been the traditional lands of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit and Métis people. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. We acknowledge that Canada's home to many diverse First Nations, Inuit and Métis people, and that many of you are joining us from one of these many traditional and treaty territories. Welcome. Just everything you're seeing, you're going to be seeing lots of things coming from our team. Just a reminder of the broad team here that's supporting the overall OHT evaluation. And today you're going to see lots of work about indicators that Luke Mondor over in the corner has been diligently working at for the last 100 days or so, pulling out all these indicators for you. And you'll be seeing lots of reports coming your way. I just want to start off with our poll to see in today's audience how many people are joining us for the first time. So is this your first event or have you joined us previously? Yes, if you've joined us previously, and no, if it's your first event. A few late entries on the people joining us. Joyce Perrin from Durham, Ontario Health Team. Melanie Young from All Nations Health Partners, welcome. Great to see people joining us from all over. All Nations is up in Cornwall, the very corner of our province. So we have with us today about 260 voted. We are at 325 people with us today so far, and most people have joined us before, but still 20%. That's about 40 people seeing us for the first time. Welcome to this event, and I think we're going to be having a great day today. There is a considerable amount of information sharing that's going to come your way throughout the overall event. But I'm just going to start off with you asked, because the chat is fast and furious, and we voice much of it, but not all of it. So a couple of questions from the last chat that we did not get to. Why don't you measure things other than a follow-up by other than physician billings? And some questions about cost and other measurements. So I'm going to take these off one at a time. So first off, why don't you measure follow-up other than by billing physicians? So we are trying to produce reports across all 42 OHTs, which ranges, from the far north to Toronto and east and west across the province. We need consistent data from everyone. That limits us significantly. In this first pass, it limits us. We're limited to track visits from non-physician providers across the entire attributed population. And if we wanted to say follow-up from other providers, and we're trying to create things on at least in this sense, on a fairly comparable basis. I appreciate that salaried models of physicians are not going to be included here. And we're missing out on all the other great providers that might be reaching out to patients after a hospitalization. These are accepted indicators, and for now, we live with this limitation. When we can add standardized visit data, and we pursue data acquisition and expansion all the time, we will add that, and then actually look to see, does it matter if it's a physician or someone else that follows up with you after a hospitalization? We had a question about our cost measure, whether community programs and programmatic budgets were included, because these might be allocated on the part of the ministry or something separate from utilization. So our measure of patient-specific costs includes all encounters in the health system that are paid for by the Ministry of Health or the Ministry of Long-Term Care, for which we have individually identified records tracked by OHIP numbers. That's how we get in. Programmatic funding that is not attributable to individual services, so community mental health, program budgets, surge, these things, they're not attributable to individuals. They're not included. We've tracked back, we cover about 76% of all healthcare service costs in this cost measure, and we have a report, and this will be posted online after, and you can dig it up from our person level costing guidelines. And finally, this is kind of interesting. What are other countries that are more advanced in population health management from the February webinar measuring? So this kind of combines what we're talking about in terms of measures and population health management. So a few examples, one from the United States for accountable care organizations. CMS sets out a measurement sets into 4 domains, one being patient and care experience, care coordination, preventative health, and disease management. And some of the indicators are, patient ratings of doctors, access to specialists, mostly on the preventative health, it's immunizations, vaccinations, and screening. And then they do have some, the diabetes composite measure of hemoglobin, blood pressure, non-use of tobacco, things like this. So they have an extensive set that they've come up with that is about care quality. They're aiming for a quadruple aim. So the others, another example, Gesundheitskennzehntal in Germany, their total cost and hospitalizations, and they have a focus with the quadruple aim on patient and provider experience measures as well. And individual providers receive condition-specific quality indicators. They don't report them out, but they do have internal data sets for that purpose. Another example, Northwest London in the United Kingdom, they have a focus on ED and hospital use, and also they have condition-specific quality that are measured through their quality and outcomes framework from their physician EMR records. And they also have surveys for patient and provider experience. So you'll see we fit within this frame. We don't have quality measures on specific conditions or diseases at this point. As we start to get closer to population coverage, I think we might start to think more about that. But we're focused on some of the target populations that people have highlighted. So with us today, we're going to present some indicators, but get bored of looking at indicators. So we have some fantastic guests for the entertainment and quality value. We're going to start off with Paul Kurdiak. He's a psychiatrist and clinician scientist at CAMH and the chair of the Addiction and Mental Health Policy at the Institute for Health Policy Management and Evaluation. He's also clinical lead for the Mental Health and Addictions Center of Excellence. And it's in that role that we ended up inviting Paul to join us today. We also have Kelly Kay with us today, and she's the executive director of the Provincial Geriatrics Leadership Office. And she has an MA in leadership, and she's a PhD candidate in adult education, community development, and life course in aging at the University of Toronto. And she's really been researching health system design for older adults living with complex health conditions. Finally, we have Bo Green, who's joining us today. And Bo is a senior methodologist who's been working in health analytics for 3 decades to teach us a few things and has expertise in data integration, modeling, clinical planning, and forecasting. And he's supporting the OPCN and he's with us today. We're going to talk a quick little introduction to population-specific activity. Ruth's going to start us off, and then we're going to head right into 3 chapters: a focus on mental health, a focus on older adults, and finally a focus on palliative and end-of-life care. And you are going to see some more reports, and I want to spend just a few minutes at the end giving you some tips on how to read our reports. So without further ado, I am going to head it over to Ruth, and I will check in on the chat. I see there have been some comments. We have a lot to cover today, so we're going to keep going at this moment. Go ahead, Ruth.
Thanks, Walter. Good afternoon, everybody, and thank you for joining us again to talk about indicators. And we want to now measure and evaluate indicators across the OHT attributable population, again, using routinely collected health data, but focusing on the top 3 priority populations identified among the OHTs, and that being the mental health, in addictions, frail older adults, and end of life, with the aim here today to describe the variation in these indicators in these target population, as well as identify where opportunities and challenges exist to better integrate care. Next slide, please. Reminding everybody that this work is based on the OHT attributable population model database. So again, it's mapping individuals to the primary care providers, and then the primary care providers to where they admit patients typically. So it's the network of people, not so much the geography that we're paying attention. It's where the patients or population, the network of physicians and hospitals that they have utilized. And it's closed right now. It has a fixed cohort based on what was going on in 2017. Sorry. Next slide. Also to remind you that we are looking at all these indicators through an equity lens. And the measure of equity that we are using is the Material Deprivation Index, which is derived from census data, 2016 census data. And it's at the level of the dissemination area, so around 400 to 700 people. And this index focuses on income, education, family structure, and housing quality. So it's ability to, and it measures access to and ability to attain basic material needs. It's closely connected to poverty and linked to poor outcomes. So this leads us to believe that there will be some OHTs will face challenges in attaining improvement on these indicators, and there will be a need to address equity at a local level. So this bar chart is 42 OHTs. I know it's difficult to see, but it's ranked by the OHT with the highest proportion of their population that lives in a deprived area. So we created this index, made them into quintiles, and comparing the most deprived to the least deprived. So you'll see at the top, some OHTs have a third of their attributed population that are residing in the most deprived areas, being those darker blue. And yet down at the bottom, you have some OHTs that have almost half of their attributable population are living in more affluent or least deprived areas. Next slide. So how did we come up with our indicators for these top 3 priority populations? It was the same process used for each of the conditions. We looked through various reports put out by ICES, Health Quality Ontario, Palliative Care Network, Frailty Network, and narrowed down to about 30 to 25 indicators per target population. And then we, as a group at HSPN, use a modified Delphi approach to come up with less than 10 to then go to our expert centers like the Mental Health and Addiction, Mental Health Center and Addiction Center for Excellence, the Provincial Geriatrics Leadership Office, and the Ontario Palliative Care Network to help us narrow it down even further to come up with a little over 5 indicators to report on across the OHTs. Next slide. I'm going to pass it over to Luke now, who is going to take us through a subset of those indicators that were just on the previous slide. because we need to get through a lot of material today, so we're not going to go through them all. Luke.
Thanks, Ruth. So just starting off with the list of the indicators that we're going to be looking at for the mental health and addictions specific populations. We're going to be talking today about frequent ED visits. ED visits as the first point of contact for mental health and addictions care. Outpatient physician visits within 7 days of a mental health and addictions hospital discharge. We will also be reporting on repeat ED visits for mental health and addictions. These are ED visits separated by 30 days, similar to a readmissions indicator, as well as the rate of ED visits for deliberate self-harm. The indicator specifications for all of these measures that we're going to be talking about here and throughout this presentation will be made available in our reporting. And all indicators that we are presenting are risk adjusted for age and sex. And this makes the OHT level estimates a little bit more comparable. Next slide, please. So starting off, frequent ED visits for mental health and addictions related care. This is, frequent ED visits may be an indication that people do not have access to the community-based services that they may need. And what we're measuring here is among those people that have an ED visit in the reporting period, what proportion have 4 or more ED visits within the prior year. So it's a risk-adjusted proportion here that we're looking at, again, adjusted for age and sex. If you've joined us in the past, you will be familiar with that top panel in this figure. And I'm going to spend a little bit more time on this first indicator just to kind of lay out how we're presenting these, and then we're going to pick it up and go a little faster as we go. But what you're looking at there in the top panel, this shows the most recent year of data that we analyzed, 2019, 2020. The data points, there's 42 points on that plot, each represent an OHT. And the points are the risk-adjusted estimates, and they're ordered from left to right, from the more desirable value to the less desirable values here. And the dotted line there shows the overall average in the attributable population database. Each dot or OHT estimate is color-coded according to the OHT's ratio of the population residing in the most versus the least deprived areas of Ontario. And so from this coloring, you can just see visually whether there's an association with the size of the least or most deprived areas in an OHT and the risk-adjusted outcome. So for this measure, roughly 10% of folks that had an ED visit had 4 or more in the past year overall. At the OHT level, the range goes from about 6% to 17%, so roughly a 3-fold difference there, which is we would interpret as high variability across the OHTs. Arguably, there's some outliers on the right there, but when we include them in, there's some pretty high variability across the OHTs. Those dark blue points are scattered throughout the entire distribution. So we're not really seeing a correlation between the risk-adjusted outcome and the proportion or the concentration of the population residing in the most deprived areas. When we put a correlation statistic on that, it's 0.15, which is a weak correlation overall. So this top panel really shows how an OHT performs overall. If you're an OHT close to the right, you're a little higher than you probably want to be. The bottom panel, in contrast, actually looks within OHTs. And what we're showing here is the risk-adjusted outcome within OHTs in the most deprived areas compared to the least deprived areas. So a value greater than 1 means that the outcome is higher in the most deprived areas relative to the least deprived areas. And a value less than 1 would suggest the opposite, of course. So values close to 1, therefore, mean that the outcome is comparable in material deprivation quintile 5 as it is in quintile 1. For this particular measure, you can see that the most OHTs have a higher outcome in the most deprived areas of Ontario than in the least deprived. And so what this means is the outcome is, or to improve the outcome overall, you could consider focusing on improving or providing resources or interventions to the most deprived areas in order to improve their outcome overall. Next slide. So our second indicator, ED visits as the first point of contact for mental health and addictions related care. So obviously when community-based services are unavailable, individuals may access the ED as the first point of contact. So what we're looking at here again is among those people that had an ED visit in the year, what proportion did not have a prior mental health and addictions related service contact 2 years prior to that incident event. We're looking at hospitalizations, ED visits, and physician visits. Is what we're considering there. Again, this is a risk-adjusted proportion. Overall, about 29% is what we're seeing in the full attributable population database in 2019-2020. At the OHT level, the estimates range from about 19% to 41%, so about a twofold difference there, which is indicative of high variability across the OHTs. Those dark blue points there are concentrated more towards the right, but still they span into the center of the distribution there. And so there's still a weak correlation with the size or the proportion of the population that reside in the most deprived areas within OHTs and how well an OHT does on this outcome. Turning to the bottom panel now, interesting, if you wouldn't mind just going back one sec. Just the bottom panel there shows actually for this outcome, most OHTs perform the same in the population residing in the most deprived areas and the population residing in the least deprived areas. You can go to the next slide now, please. So last one we're going to look at here is outpatient visits within 7 days of a mental health and addictions specific discharge. So timely follow-up with a physician after discharge may help improve adherence to treatment and reduce the likelihood of hospital readmissions. Outpatient visits after discharge are a good thing. You see, again, this plot goes from high to low, left to right, because we want to see a higher value here. The overall population, overall estimate in the population is about 34%. At the OHT level, estimates range from 19 to 49%. Those dark blue points are concentrated more towards the right on this one, to the least desirable values there. And when we put a correlation on that, it's 0.37, which means that performance is weak to moderately associated with the size of the most deprived, most or least deprived areas. And again, similar to the last indicator we looked at, most OHTs here have a comparable outcome for their population that resides in the most versus the least deprived areas. You'll see there are some missing values on this plot. We are suppressing information where there are a small number of events or where the population is not quite large enough, just because those estimates are a little unstable. And with that, I'm going to hand it over to Paul Kurdiak.
Thank you, Luke, and thank you to the HSPN team and Walter and Ruth for inviting me. I'm going to try and be brief because I want to leave lots of time for discussion, but I've assembled some high-level thoughts on the issue related to thinking about a population-based approach for mental health and addictions issues within OHTs. So next slide. Thank you. Oops, yeah, thanks. So this is just a signal that there is some work going on that's quite relevant, led by Brian Rush and Daniel Vigo, funded, I think, by Health Canada. And the exercise here is to take a whole bunch of diverse types of evidence to estimate need for various disorders, and then to kind of estimate what types of, what proportion of services are required along the severity spectrum of each disorder. So, an example would be, alcohol use disorder. There would be a population-based sort of general prevention approach, and then there would be a much greater, like a group of a large number of individuals who have mild disorders where you'd want to get them sort of early intervention and self-management. And there's an initiative like this in Ontario now, all the way up to, residential treatment for people with severe and complex alcohol use disorders. And you could do this for any number. They are doing this for a whole host of disorders. But just to let you know that this exercise is occurring in parallel, and I think will be quite useful for OHTs when it comes out to help understand, the population-based burden in your region, and then the kind of services that you have, and then to try to do an alignment or realignment accordingly. Next slide. So this was a signal for me to say, the indicators that Luke went through are great, and I feel that way because my team's done a lot of work to develop them, and it was really interesting to see the variation across regions. But I feel like they're very high level, and it's hard to know how you would drill down on a particular population. And in many ways, I feel like the challenge of taking a population-based approach for mental health and addictions within OHTs is a very similar challenge that we're dealing with within the Center of Excellence as we think about what our first priorities are. And the issues relate to the fact that most mental disorders, with the exception of child-specific ones that only occur in the young, and things like dementia that occur in the old, mental illnesses and addictions have a young age of onset in sort of late adolescence and early adulthood, but then people sort of live with the disorder for a long period of time. And the nature of the impact of these disorders differs based on age. And obviously I'm not telling you anything you don't know, but there's a huge number of different disorders. There are a large number of mental illnesses. There's a large number of addictions. There's often complicated comorbidity. And each one of those disorders has its own evidence-based interventions, and these things differ by disorder. So there's a huge amount of variability. And I guess the last point is, as I stated with the alcohol use disorder example, each disorder has its own severity and complexity spectrum, and most start with low impact all the way up to like highly severe treatment refractory situations. So when you're faced with this amount of diversity and complexity, what we've come to the conclusion is in the Center of Excellence is, especially when you think about the fact that our mental health system is not much of a system at all, that you could start anywhere, really. I mean, the bad news is there's no obvious place to start. The good news is then start anywhere. And what we've come to the conclusion is that no matter where you start, a population-based and programmatic approach is more important than a particular population of interest. And I'll explain what I mean by that in my next slide. So again, you could choose anything. There are better and worse cases for choosing depression, anxiety disorders, alcohol use disorders, other disorders like schizophrenia that are rare and tend to be more of the sort of complex, high cost, probably are less OHT and more regional intensive management. But here's the case for depression, and again, you could make the case for anxiety or alcohol use disorder. But for depression, it's highly prevalent. It occurs in about 1 in 20 individuals. It afflicts an incredible toll on the individuals who struggle with it. We know from Statistics Canada data that between 2002 and more recently, depression was accurately detected initially in 2002 in a third of individuals who had the disorder. Now we're accurately diagnosing about a half. Among those who are diagnosed accurately with depression, we know that there's an incredible amount of variability in the quality of the treatment. And we also know that there's really bad access to specialty care. And we also know, and this is what we're trying to deal with in the province, is that for people with mild to moderate disorders, every guideline suggests that cognitive behavioral therapy and perhaps some other types of therapies, but mostly cognitive behavioral therapy, is a first-line treatment. And this is essentially unavailable in our publicly funded system. And there's so much data coming from south of the border where they've integrated depression screening and depression algorithmic management especially within HMOs, that when you successfully and algorithmically treat depression according to evidence-based standards and guidelines, that not only do people get better from the perspective of depression, but there's a cost offset because people with chronic medical conditions like hypertension and diabetes actually do a better job at self-management when they are no longer depressed and incur fewer costs associated with the non-depression related comorbidities like asthma, diabetes, and hypertension. So that's even more of a case for suggesting that depression might be a nice place to start. Next slide. The final thing is that what I just mentioned previously, the way this works in the US, in fact, the entire state of Utah has now integrated what's called team-based care. They have somebody integrated into their primary care clinics whose job it is to routinely screen individuals for depression. Once a case is detected, then the individual is offered a suite of services that are evidence-based and algorithmic and measurement-based to start them with a treatment of depression. And then in Ontario, what we are in the middle of is a replication of this unbelievable mental health intervention in England led by David Clark, where he and his team made CBT for depression and anxiety related disorders publicly available. So if we know from other jurisdictions how to integrate measurement-based pharmacotherapy into primary care, and we are developing province-wide, in parallel, province-wide availability of an evidence-based CBT program, then you start to have the opportunity within primary care to make the case for routine screening of depression because you have something to do with them. I mean, historically, primary care has been reluctant to routinely screen for depression for case finding, precisely because there was no confidence that anything good would come of it. In other words, it was an indictment of the poor state of the mental health system. The other benefit of this is, from an OHT perspective, is if you start getting into availability of measurement-based care, either pharmacotherapy or CBT, you start to get into routine treatment refractoriness, or people who are not responding to first-line care, which then means you can then start organizing your mental health services that are more tertiary in nature and specialty in nature within your region to focus on the individuals they should be focusing on. And there's no such opportunity to funnel treatment refractory individuals into those precious resources currently. So I just wanted to, I could make the same case for alcohol. I could make the same case for anxiety disorders, also very common. But I just wanted to sort of float this out as an idea before we have a discussion, to say that there is a way forward, and this programmatic playbook is what's led to success in the cancer system, in the renal system, in the palliative care system. And we've often thought mental health is too complex. And what I'm saying is, from the Center of Excellence, we need to do this same programmatic care for a whole host of populations with specific disorders, for depression, for anxiety, for alcohol, but we have to start somewhere. And it might be a nice opportunity as OHTs evolve their thinking on mental health and addictions. And I'm very pleased to see that mental health and addictions is such a high priority. that we collectively focus on one or two disorders for which we know that there's a high burden, for which we know there's an evidence base that works, for which we know there are standards that have been developed on the basis of those evidence, and for which we know there are outcomes to monitor once people start receiving evidence-based treatment. So I'll stop there and we'll entertain a discussion. Thank you.
Super. Thanks very much, Paul. And just to kick off the discussion a little bit, we're going to have a poll here, just to reflect, and then I have a discussion question next. Thinking about focusing on people with mental health and addictions. If you are thinking about all people, if you have specific populations in mind, and I've just listed a few here: youth, severe mental health, or less severe, such as Paul's example of. And so I am going to pop up a poll so that you can respond in here, and you can choose as many options as apply. In this case, I believe I have set it up that way this time. So we'll gather, and I think it'll be useful to think about how you've been thinking about your population. And Pete, there's a couple of questions coming up here in the chat. There's going to be some acronyms, and Paul, I'm hoping you're going to need them, or other people will know. Someone was suggesting hospital populations seeming to prefer DBT to help with self-regulation.
Yeah, so I'm happy to field that. So that would be another population. DBT and DBT skills-based training is an evidence-based, especially DBT is called dialectical behavior therapy. It's an evidence-based treatment for people with borderline personality disorder, this is an identifiable population. Another example of how you could focus in on a particular individual. Again, to me, there's an evidence base, there's an identifiable population, there are outcomes you could focus on. It's a totally legitimate area of focus. Complex patients really suffer, really struggle, and very few services for this population could easily get behind it. And it's not, but I think there would be huge benefit of limiting the number of different types of interventions so we could learn provincially about how to do this programmatically, because we've done such a historically bad job of it in the mental health and addictions sector.
Yeah, I think that sharing of learning, right, is a real essential piece. And I think across OHTs try to do that as much as possible. From some people had some comments in the chat about other populations. This was just a sample set, like people with substance abuse that wasn't on this list. But you can see here, a lot of people just thinking about mental health equally. And so starting to think, I think, about more focused target populations is one of your suggestions there. What are your thoughts on implementing case detection and screening? So if you want to highlight into the chat, and remember, if you're typing into the chat, to make sure people are doing much better today, I think, on all panelists and attendees. They heard my call. What you think about this? And I think there's a really good comment up there from, I saw it go by, and that was around, it was, I can't, Neil Nake, almost as if the OHT as a whole should be doing mental health screening rather than leaving it to the primary care provider. One provider bias, but I think, that's a great idea. And I was just trying to think about everywhere, particularly the places where there's going to be contact, right? Wherever the patients are going to be contacting, and to really have that first ideas. And see somebody commenting around seeing an addiction focus with mild to moderate mental health, and it's an invisible disease. I know that someone was asking me the other day about how do we know more about the levels of depression or mental health in the community. And I remember a project we did a few years back. There was just a dearth of data available on mental health, because it really is not seen, it's not coded, it's not diagnosed. And I think what you're getting at there, Paul, is maybe to see if there's some ways we can do this in a more comprehensive way. What do people think about that ability to do screening in a way that makes it available across the OHT too, right? So that we can start doing it. Okay, now the chat's picking up. Assessments need to be consistent and easily accessible. Do you have a recommended approach? Like I've seen people using either the GAD and older populations, but also there's the PC something 3.
Yeah, there's a PCL3, there's PHQ9. Yeah, PHQ9 and GAD7 is what Neil has recommended. Those are probably the most frequently used in primary care across internationally to screen for depression and generalized anxiety, respectively.
Yeah, I think I've seen that PHQ9 used in a number of primary care settings and federally qualified medical centers. I think it's a standard across the United States. So being good. And we do need to be mindful of screening cultural competencies, absolutely. And I think it builds right in, we have an equity measure here that talks about deprivation, but we need to be very, very conscious of other types of inequities in the system, including very much race, gender, and others, and that plays into this as well very much. Someone's asking a question around including the wide autism spectrum. So I think that's going to be one of the target populations again, and it's deciding whether people are doing different things in different areas. I mean, I think that's a priority. People with developmental disabilities, possibly fitting here a little bit as well, and having those tailored interventions though. So I think, as much as possible, if we have some common areas that people are working in, then we can accelerate that sharing across OHTs, which will, I think, help with everybody. And again, comments around screening from ASHNOR, many of mental health clients not being well connected to primary care, so being really careful about, and so there's the screening bit, and then there's how do we get them connected to the service. We need to think about both sides. Did you want to add anything there, Paul? And,
no, I was. The comments are great, and I think you're starting to see in the comments like there's a tremendous desire to respond to the overabundance of need across the entire mental health and addiction sector. And I would just say that the best thing we can do is to emulate the success that has been observed in other areas of the healthcare sector by how we do it, in as much as the focus on what we do. If we can show within the mental health sector across OHTs that we can systematically identify individuals, give them evidence-based treatment, and monitor outcomes. In doing so, we'll have to build a skill set and infrastructure on measuring and monitoring that we can then leverage to move on to the next thing and the next thing and the next thing. But and the flip side is if what occurs across OHTs is people kind of decide to go it alone and also stray from evidence in a programmatic approach, I think we'll lose the opportunity for that sort of mass learning that comes from everybody focusing in on a particular issue and problem.
Right, great. Thanks for sharing that. And I'm going to come back to our deck now and close out the chat. There might be some other responses to add into. There was a comment around home care fitting in. Certainly, community mental health services fit in. So keep that chat alive and your discussion running. We're going to turn now to a focus on older adults, and I think Luke, you'll be back with us for some indicators first, and then we have Kelly coming up.
Thanks, Walter. So the indicators for the older frail adults that we will be looking at or reporting on include frailty, having 2 or more fall-related ED visits amongst the frail population, as well as days at home amongst the frail population. As well, we will be reporting on a number of indicators specific to the home care sector, including activities of daily living, cognitive impairment, caregiver distress, and health-related quality of life. For ADL and health-related quality of life as well, we're also reporting on changes in these scores for the home care population. Next slide, please. So starting off with frailty, well, what is frailty? First of all, it's an attribute of aged people who are at increased risk of adverse health outcomes, including death and transitions to higher levels of care as a consequence of diminished ability to respond to stresses, which are often a result of the accumulation of multiple deficits. Multiple ways to operationalize frailty. We've adopted a definition from the PGLO that uses health administrative data in Ontario across multiple sectors. And so what we're looking at here is the proportion of older adults, age 66 plus, that have either a history of dementia or that are residents of long-term care facilities, or that have palliative care, or that have 2 or more of the following 7 conditions, being cognitive impairment, incontinence, falls, nutritional or functional difficulties, targeted health services utilization, decline in general health status. Again, that's a pretty loaded definition. All of our specifications for how to define these will be in our reports. Oh, I just want my pop them back 1 sec. Thanks. So for frailty, overall, about just shy of 13% of older adults meet this frail definition. At the OHT level, the range is from about 10% to just shy of 17%, which is modest variability across the OHTs. And those dark blue points you can see are scattered throughout the distribution there. So it's a fairly weak correlation with the size of the deprivation population. The statistic is about 0.17. That's the top panel. The bottom panel, again, shows that most OHTs, the outcome or the proportion of the frail population is greater in the most, amongst the population residing in the most deprived areas of Ontario than in the least deprived areas of Ontario. Again, that might give indication on where to focus resources. Yeah, next slide, please. So 2 or more ED visits for fall-related injuries amongst the frail population. So here we are looking at the denominator here is the population that is considered frail from our past indicator there. And here we are looking at what proportion have an ED visit in the reporting period and, an ED visit for a fall-related injury in the reporting period, and a second that occurs within 365 days of that index event. About 2.5% meet this definition in the older or the attributable population database. High variability across the OHTs. The range is from about 1.8 to just shy of 4%. And there's an overall weak correlation between the size of the population residing in the most deprived areas of Ontario with this outcome at the OHT level. Interestingly, for this one, actually, some OHTs have a higher proportion of the outcome in the least deprived. Others have a higher proportion in the most deprived, and others are fairly equal. So there's a pretty wide variability in the estimates being in material deprivation quintile 1 or quintile 5 across all 42 OHTs. And then jumping to our last indicator, ADL long. So this is among home care clients. We are looking at people that had our inter-RI HC assessment in the reporting period. For people that had more than one RI assessment, we're taking the most recent estimate. ADL, it measures a person's ability to perform activities of daily living. It includes things like personal hygiene, dressing, locomotion, toilet use, bed mobility, and eating. Scores range from 0 to 28. Higher scores are worse. They're indicative of more dependence in ADL performance. And so here we are reporting the mean ADL score at the OHT level. Overall in the population, the average score is 7.9% or 7.9 amongst the home care clients in the attributable population. At the OHT level, the range goes from about 4.5 to 10.5. Again, high variability across the OHTs. and a weak correlation with the size of the population residing in the most deprived areas. The bottom panel again shows the ratio of the outcome in the most versus the least deprived areas. And again, it hovers 1 here, meaning that the outcome is comparable in Q5 as it is in Q1 across all OHTs. And with ADL scores, we've also looked at change in ADL scores among people that have two or more inter-RI assessments in the reporting period. If you could switch the slide, please.
Oh, thanks a lot, Luke. And we're going to put this one up quickly here and just pop it through that we have looked at this change score. I'm a little running on time. We're going to go past the change score and people will see it in the individual reports. And we're going to move on right to Kelly and hear from the PGLO on some of their thoughts. So thanks, and we'll be back in a few minutes with some end-of-life ones.
Thanks very much, and thank you for the invitation to present to the group. We can go to the next slide. I'm going to speak to you specifically about a project that Provincial Geriatrics Leadership on Ontario is undertaking that expands on some of the work that you're hearing about today. Just a reminder for those who haven't met us yet, PGLO is funded by the Ministry of Health and coordinates perspectives across clinical geriatric services. And I'm joined today by my colleague, Adam Morrison, who you may see popping into the chat with resources as your questions come in. So we're part of a network of more than 440 programs and services that are focused specifically on the older adult living with frailty. And this expertise is available to you in the development of initiatives, programs, and innovations. And here's a link here in case you haven't met us yet, so you can find out more about us. We can go to the next slide. And this is just a quick overview of who your local resources are. So if you haven't had the chance to connect yet, at the provincial level, we're doing the work you see here, the capacity planning work, clinical model development, performance measurement and evaluation, which I'll talk to today, and knowledge creation and policy development. And at the meso level, at our regional level, we have many regional partners that you see listed here. If you haven't met them yet, please follow the link and learn more about them, because you'll probably see them in action at the local level with many of your patients. Let's go to the next slide and I'll speak specifically about this project. So the genesis for the Indicators for Integrated Older Persons Care in Ontario initiative really started out of a core deliverable expected of us by the ministry, but we're seeking to answer the question, what ought to be measured? It's a little bit different than the question of what can be measured with existing data sets. We want to know what ought to be measured related to integrated care for older people living with complex and chronic health concerns. And this question has been informed by an extensive review of the literature and the on-the-ground experience that of all those many people I've mentioned earlier. And it's a bit of a response to the disjuncture between what gets measured, counted, and funded, and what actually matters to older adults and caregivers. Let's go to the next slide. So this work is founded on some earlier work we did. We did a scoping review to identify design elements for integrated care for older people living with complex and chronic health needs. And this is available to you at the link you see here. I'll get Adam to pop that in the chat for you so that you can access that easily. We identified 13 design elements that might be helpful to you as you're going about your program design. We also have a gradient of what high-level implementation looks like versus other levels of implementation. So do check that out. But it has spawned this particular project. We'll go to the next slide. So this project is really bringing together older people, caregivers, health professionals, researchers, policymakers, everyone we can think of, to come up with a performance measurement framework, indicators, data collection tools, et cetera, that are going to support the collection of consistent, measurable, reliable data from specialized geriatric services and Ontario health teams and others. So that's really the crux of this. We'll go on to the next slide and I'll share with you the various parts of the project. We're here in the middle in a consensus process that's about to launch next week. And I'm going to give you an update on the environmental scan we've completed so far, and then we'll be moving on to develop tools for performance measurement. So let's go on to the next slide. So just to fill you in on where we are with the work we've done, we've identified 61 data sets that were vetted by our project team and committee From these data sets, we identified 1,900 potential indicators. Now, don't get upset. I know that sounds like a lot that we brought forward for consideration. We did review these against inclusion and our exclusion criteria. We were really looking for indicators that would help with measurement of an integrated system of care for older adults. So we removed over 600 that didn't initially meet the inclusion criteria, and we removed another 700 that were not really specific to the older adult or were too program specific. We consolidated duplicates. I've highlighted the fact that we've also entertained novel indicators, and that will be part of our process going forward. We do not have a healthcare system that's designed with the older adult in mind, so existing data sets may or may not be capturing the kinds of indicators that need to be captured for older adults, and there may be a need for novel indicators. We're defining each of the indicators or extracting definitions, and we're at the place where we've got about 300 to 400 indicators that are going to be reviewed by a stakeholder advisory group that will begin next week. The goal is to arrive at a core set of indicators to inform performance measurement at micro, meso, and macro levels. And so there'll be some information here to be quite useful to your OHTs. Let's go to the next slide. I just want to share with you how we're going to decide how our selection process will unfold. We are using indicator selection criteria developed by Ontario Health. Certainly in the first round, we have one criterion, and then we have 8 other criterion that we'll be putting our process through, all those indicators through as we get into a second round, and some have arisen out of our scoping review and are specific to apply to being applicable to people living with multimorbidity. Unlike Paul's comment earlier, really the challenge in designing for the older person living with frailty is not to follow a single disease, but in fact to design for multimorbidity. Let's go on to the next slide. So here's how you can get involved. You can participate in the consensus building process. So if there's a few OHTs that are interested in joining in, please contact me and I'll share with you the recruitment information about that process. There's also space for several OHTs to attend a clinician feedback session planned in June. And you can also sign up for our digital town hall. That's an asynchronous way to stay in touch with what's going on, specific to the topic of older persons care, or our monthly newsletter. Now, we can go on to the next slide, a quick glimpse at the project committee. We couldn't be doing this work without all these other individuals that are behind this work. So I really want to celebrate their contributions. Some of them are on the call today. And let's move forward 2 slides, please. I certainly wanted to leave you with some things you could use today. So if you could just take a look here, I want to let you know about the census that we're doing of programs and services for older adults. And this is something you can participate in. So the Asset Mapping Initiative is an initiative that helps to identify and collect data about various programs and services that are delivering focused care to older adults. This is a contributor designed and led secure database that has historically been collecting information from specialized geriatric services, but has recently been updated to take data that comes from Ontario Health teams who are developing focused programs and services. The link there is a little bit cut off, so I'll ask Adam to just hunt for the correct link and pop it into the chat for you. But the next call for data for the 2021 year will come in September 2021, and that's 2020-2021 data. But if the portal is now live, if you have prior year data that you would like to add, and this helps us to capture a census of all the various models, the innovations, and the volume and utilization data. Let's go to the next slide. I also want to let you know that we currently have an online course running to support caregivers of older adults living with complexity or frailty. These are the topics that are covered, and we also have a handbook published in 4 languages that can be helpful. So if you're encountering people now who are caring for older adults living with frailty and need support, this is available. And last, I want to share with you, as you're working to develop your programs and services for older adults living with frailty, certainly your team members may be reflecting on what they need to know. We have a competency framework that describes the role for the interprofessional team members in the comprehensive geriatric assessment work, which is a gold standard for older persons care. There's also a self-assessment tool that will help you evaluate your own learning needs, and a compendium of educational resources that goes along with that to help you fill any learning gaps you identify. So you can click on those links and follow along. And one other tool that we have that I haven't referenced here is access to frailty estimates. Unlike, we have the advantage of having a validated index that has allowed us to calculate and estimate the prevalence of frailty in every census division in Ontario, and that's posted on our website for your use. And that takes me to the end. If you'd like to put up my last slide, it has my contact information. Thank you very much.
That's really fantastic. Thank you so much, Kelly, for sharing all that. I mean, you can see that there's a wealth of resources, and we're coming in with a few indicators just as the PGLO is heading into a much larger initiative. So you got a sense here of how people in Ontario might be already engaging with specialized geriatric services. So let me just launch up this poll, and people can identify in how they might be working with your local specialized geriatric services around this. You know, we've thought about, you know, as people engage and identify these target populations, how do you engage? Okay, so people are starting to vote in. If you're not working with older adults, there's an option for you there. And if we've missed some important pieces, then you can use the chat to add them in. Somebody asked about, thank you, Kelly, for a wonderful presentation, and including some other comments are including data. Thanks, Kelly. The slides will be shared online on our website. You will receive an email if you're at this. Okay, I'm gonna end this off and share the results out. And we can see actually the good news is that most people are already engaging with their local geriatrics group. So I think that's good news, I think, Kelly. But still more opportunity. Other people are planning 20%, and then some people who don't know. So now you have Kelly's contact information, and you can get in touch with them. One of the discussion questions we thought, and Kelly was actually very interested in, you know, as they support they've got a whole tab on their website. I know it says Ontario Health Teams, click here, so you know where to go. But what are the most helpful sorts of practical information that you need to help plan and design services? So again, people have been doing a very good job today of chatting to panelists and attendees. So what are some of the things that you're thinking about? And I saw somebody earlier mention something around geography and a gap in service availability at all. So I don't know how that plays out, or what you might say, Kelly, about regional variation in services that are available for older persons. What do you think about that?
Mm-hmm. I think first thing is to understand what's actually out there. So just trying to encourage participation in our census to the extent possible. It does help paint a very clear picture of where there are significant gaps. And then taking a page out of Paul's book earlier, being able to define and describe what the core services are that ought to be available in every OHT. And that's work that we're beginning as well. We do like the way that Paul portrayed that. So you may see something that looks familiar. But I think what we do know is that there's about 26 different kinds of services that are identified in our current asset map. It's probably, there's probably not a lot of distinction between some of them. So we really need to get to the essential services that ought to be available everywhere. And I think having a complete census helps us see where the gaps are. So I just would urge anyone who is working in the area of older persons care to participate, and encourage others to do so that we can see where those gaps truly are.
Yeah, there are some comments in the chat that are going to provide some suggestions to you, I think, around, you know, offering information on existing effective primary care prevention programs. I guess that's mostly mobility would be one of the big areas, I would think. People are talking about using a Rockwood scale for frailty assessment. I know that in the UK, they have the EFI, or the Electronic Frailty Index, in every physician's record. They also have the PHQ-9 and the patient activation scale and some other things that they have at that front line. Last question I'll leave just before we move off, and I don't know, this could be a very, very big question, so try and just have your thought on this, is just as you said, without having a disease-specific focus for older adults,
Mhm.
and there are going to be a wide array then of different types of services that might best meet their needs depending on where they are. I've seen programs like GRACE and PACE and others, and I've always wondered about how do they figure out how to titrate which services for which people, because you can't, it's not a good idea to give everybody everything, right? Where have you seen that done well?
Well, let me tell you a little bit about what geriatrics care looks like. So in a chart review of 38 charts that I did with my colleagues working in geriatric services, we found over 325 interventions that were required to support those individuals to remain living at home. And so that's what we need to be thinking about when we think about design, that we need to describe what's required, and the standardization in older persons care comes at the level of the comprehensive assessment, doing that in a fulsome way, and you'll see more about that in our competency framework. And then allowing the interprofessional team the freedom to identify the interventions that are going to address the specific and multifaceted concerns that arise for the individual. And that isn't wasting resources. That's what it takes to support people to stay living at home. And we've seen many examples in the many community-based geriatric services in concert with primary care and home care services who've been able to maintain people at home. And if you can keep people at home even an extra year longer than they would have without your support, that's quite a savings when you add that up from a long-term care bed perspective. So I really do think that it's a different way of planning and constructing services. I also want to just touch quickly on the clinical frailty scale and the identification of frailty. I see that people are using that. That's great. I just would urge that if you're using it, that you make sure that you're doing it from a place of really knowing the person well. Primary care knows their patient population very well. They have that longitudinal advantage. And using the clinical frailty scale, I think there's been some excellent work done in Hamilton to use the clinical frailty scale. As well, geriatric services get to know people very well because they do deep and thorough assessments. But just taking a clinical frailty scale and checking it off on your first instance of meeting someone is no better than an end of the bedogram, and you might make assumptions that are not accurate. So just use those tools properly. And as well, if you're working in the emergency area, start to take advantage of the CTES frailty modifier so that we can understand where frailty is everywhere in our system.
That's fantastic. Thanks, Kelly. And I'm seeing other comments coming in, and particularly I think some of these coming from patient perspectives as well, and really needing to have a patient-centered approach here. And I think we need to be asking providers and patients if they are capable of really getting on and doing that really well. We might run a whole session on goal-oriented care. We have a research program that focuses into this space sometimes. Thanks very much. Luke's back to talk about some of our end-of-life and palliative indicators. And I'm just going to say, Luke, let's try and keep it super, super brief on the indicator side so we can hear.
Yep. Sounds good. So end-of-life indicators, next slide, please. We have 5 that we're looking at: deaths in hospital, ED visits in the last 30 days of life, palliative home visits in the last 90 days, palliative home care in the last 90 days, as well as average days at home in the last 6 months of life. Next slide, please. So deaths in hospital. So the majority of people would prefer to die at home rather than in hospital. So this indicator measures amongst the decedent population the proportion that die in hospital, and hospitals are defined based on acute or psychiatric hospitals, emergency departments, rehab, and complex continuing care institutions. Overall, about 50% of the decedents in the attributable population dataset have a death in hospital. At the OHT level, that varies from about 38% to 61%, which is modest to high variability across the OHTs. And we can see that that there's a weak correlation with deprivation. Those dark blue points are scattered throughout the distribution. And when we look within OHTs, there's quite a difference at the OHT level in terms of how the outcome looks in the most versus the least deprived areas, depending on which OHT you're in. Most OHTs have an outcome that is higher in the most deprived areas. Next slide, please. On-plan ED visits in the last 30 days of life. So here it's a proportion of the population that had one or more ED visits here. About 55% of decedents had one or more on-plan ED visits. At the OHT level, the range goes from 49% to 62%, which is low variability. Correlation with the size of the deprivation population is 0.24, which is a weak correlation. And again, turning to the bottom panel now, within OHTs, there's considerable variability across the OHTs, but no large deviations from one. So most OHTs perform similarly in the most deprived, and the population living in the most deprived areas relative to the least deprived areas. And our last measure that we're looking at and presenting here today, palliative physician home visits in the last 90 days of life. About 29% of decedents had a palliative physician home visit. At the OHT level, estimates range from about 13% to 39%, so high variability across the OHTs. And again, a weak correlation with deprivation. We're seeing that across these target population indicators, a weak correlation with the size of the population residing in the most deprived areas. For this particular measure, the outcome is less frequent in the most deprived areas across most OHTs, but keep in mind here that a higher value is desirable here. So there's some inequality going on there. And I believe I'm going to hand it over to Bo Green now, who is going to talk from the Palliative Care Network.
Thanks, Luke. Good afternoon, everybody. I'm just going to take you through a little bit about what the Ontario Palliative Care Network, or OPCN, is all about, and some of the reporting and indicators. And you'll see that there's pretty good synergy with the stuff that's going on at the OHTs with some of the reporting that we're doing at the OPCN as well. Okay, next slide. So the high-level mandate for the OPCN is to develop a standardized and coordinated approach to delivery of hospice palliative care in Ontario. And under this sort of high-level mandate, there are three goals. One is to be the principal advisor to government for hospice palliative care, for everything palliative care, really. And the second one is to be accountable, and that's in three main areas: performance measurement, quality improvement, and system level coordination. And the last goal is to support implementation of this coordinated, standardized approach to delivery of palliative care at the regional level. Okay, next slide. This is our governance structure, and you can see at the top there the executive oversight, which is inside of Ontario Health. But we rely heavily on clinical input, and you can see in the red box in the middle there, we have two advisory councils that have a lot of clinical representation there. So we try to use these two councils to ground our measurement work really in stuff that's going to make sense to the clinicians, but also, like, our clinicians are also researchers, and so we try to keep our methods up to date in terms of what research is happening on the ground. And you can see here there are implementation advisory council. There's a partnership advisory council. There's a coalition, which is as you can see at the note at the bottom, there's is made up of provincial associations and academic centers, and acts as an advocate for quality hospice palliative care. So there's a broad, partnership and mandate that the OPCN is undertaking. Okay, let's move into a little bit of the measurement stuff. So right now, as it stands, we have 3 reporting products. I'll go with the middle one first because it's our sort of most frequent one, and that's the performance summary report. And the intention of that report is to help with quality improvement activities. It says 3 to 6 months there. The reason is we do produce it quarterly, but every once in a while we will skip a quarter, either because we have, important upgrades happening in our repository, or other things going on, whether it's, COVID or whatever. The second one is the system level measures report, and that's our accountability report. So that's really a high level, system level report that we do annually. And the third one is the regional profiles tool. And what that one is our biggest report. Again, it's an annual report, and we put a lot of work into that one. That one allows capacity planning based and really drilling down into palliative home care service utilization at the sub-region level. So that's our most sort of comprehensive report, and it gets a lot of use. Go to the next slide. So now for the SLMR, I'll just go a little bit more into depth. So there are what we call 4 system level measures. You'll see that it's slightly more than 4, but there are 4 that have been identified to measure, progress on improving hospice palliative care. The first one is percent of caregivers of decedents who receive palliative care services who were invited to respond to the caregiver voice survey. So a little bit of explanation here. So the reason that we don't have a really comprehensive measure for, response rate to the caregiver voice survey is that the implementation of the survey is not province-wide and it's not comprehensive. So we have this measure that we use, which is, the percent of caregivers who were invited to respond. So that's kind of an interesting measure. But number 2 is percent of community dwelling decedents who received physician home visits and or palliative home care. Now, if it sounds like this is two indicators, it actually is. So we call it one measure. We often talk about it as one measure, but we represent it as 2 indicators. The third one is percent of decedents who had 1 or more ED visits in the last 30 days of life. And that's sort of a general measure of ED utilization in the last 30 days of life. And then we have a more specific measure. And as you can imagine, like in the last 30 days of life, ED visits may be completely appropriate on one end of the scale. On the other end of the scale, they may be incidental and low acuity, but still necessary. So there's another measure, which is 2 or more ED visits in the last 30 days of life, which is a more specific measure of sort of folks that are really needing to use the ED near the end of life. Thanks to my colleagues for answering the questions that are coming up in the chat. That's really helpful and saving us time as well. So the fourth one is percent of decedents who died in hospital, and that's a pretty standard end of life indicator. So if you go to the next slide, this is a sort of sample from the SLMR, and you'll see we have 9 years of data now in our repository, which gives us a nice trend line. And you can see that we've got targets towards the end here. The last 2 fiscal years, we have targets, which are the dotted lines. And you can, I think the argument could be made that when you look at these trends, what we're seeing is sort of slow and steady improvement in these measures. Okay, let's go to the next report. So the next report is the quarterly report that we produce, the performance summary report. And the indicators that we have implemented so far are the ones in the solid boxes. The ones in the dotted line boxes are the ones that we have intention to implement, but something that we will be working on in the future. And one of the things that I wanted to point out is that, the indicators that Luke showed, of the 5, we have 4 of them in our reporting. Sorry, we have all 5 of them in our reporting, I should say. So there's really good synergy between what the OHTs are doing and what the OPCN is doing in terms of reporting. Okay, next slide. So PSR, this is an example, physician home visits in the last 90 days of life. And you can see in the PSR, you can look at things at the sub-region level, which is what this graph is showing here. You can see the kind of overall trend that's happening. The dots are quarters, so you get a little bit of bouncing around going on, but you can see the trend overall, and you can see that some sub-regions, are a little bit different from others. Okay, go ahead, next slide. I'm trying to fit all this in. So here we go, the regional profiles tool. This is the one where you can really start to drill down on home care services, and you can see the different home care services listed there. You can look at ALC days in the hospital setting. You can look at location of death. And again, this is all at the sub-regional level. So if you go to the next slide, this kind of gives you an idea of the level of detail that the regional profiles tool has. And you can pick and choose sub-regions. And you can see here that we've also identified within our palliative population, our end-of-life population, significant chronic diseases, 4 of them: cancer, CHF, COPD, and dementia. So it gives even more granularity to the report. Okay, go to the next slide. So one of the things I just wanted to briefly touch on while in the last few minutes here is the reporting that we do at the OPCN is really based on retrospectively looking at days prior to death. So our main cohort is a decedent cohort, and so that's might be a little bit different from how the OHTs ultimately want to operate as care providers. So it's just something to consider, and we talked about it a little bit in preparation for this meeting, in terms of the idea that one of the big reasons that we report retrospectively is because that's how the administrative data are available, right? So there's no sort of real-time data asset that we can use to say, okay, somebody's been designated palliative, they should be in our cohort or whatever. From an OHT perspective, there's probably a pretty big incentive really to identify people as benefiting from palliative care and having them be in the OHT more in real time. So I just wanted to point that out, that subtle difference may exist, and there may be some reason for the OHT to use a different adoption of people into the OHT. if you go to the next slide. And this is kind of what I'm talking about. So the idea that palliative care and end-of-life care are two different circles, one within the other. And so we're focusing more at the OPCN right now in our reporting on end-of-life care. But the identification, early identification of people who will benefit from palliative care is something that is of interest to the OPCN. It's just not something we report all that much on right now. And I think that takes us more or less to the end. There's 2 minutes left. These are just our data sources. And again, like we try to, as much as possible, in identifying palliative care and people that are flagged as quote unquote palliative, we try to use all of the data sources that are available to us. And we're improving those definitions, all the time.
Great. Thanks, Bo. And your colleagues off on the side have been very, very active in the chat, getting to lots of the questions today.
That's great. Thanks.
And there has been quite a bit of activity, right from types of surveys or different types of predictive models. And I think this is a space that's really, really important. I'm an economist by training, and I think it's also important because we spend a lot of money, and I don't think we're always buying people what they want towards the end of life. And so there's some questions about, what do people actually want? And I think we can do a much, much better job of identifying that. My fears have come true. We've been crammed at the end, and we're going to have a very abbreviated conversation and chat here. But I will say that the colleagues have been quite active in responding. There was a question whether the OPCN has conversations with Cancer Care Ontario. I know there's a clear link sometimes end of life care, cancer care, palliative care.
So, so I actually work in Cancer Care Ontario. So I'm, supporting the OPCN, but I also work in cancer care. So we do speak, a lot with the folks in cancer care. The OPCN tries to take a more population-based approach, and the measures are more high level. But when we do, and we are releasing, this year our system quality index, our CSQI for cancer, and we're incorporating some of the palliative measures into the cancer population. So there will be some synergy there as well. So we do speak all the time, and we're always trying to figure out how methods can be applied. And
that's super. So I just want to really thank all of our guests today. I am going to find some other way of communicating with people how they might want to look at some of the indicators coming forward in our reports around our use of spider diagrams, either in a future webinar, or maybe I'll just put up like a 60-second YouTube post, and people can check it out. Thanks, Bo. Thanks, Kelly. In the background, thanks, Matthew. Thanks, Nusrat, Adam, and Paul for joining us today. And everybody else who's out there. There's still over 230 people, and we are past our time. Thanks again. And we really look forward to seeing you next month. We're talking patient and provider surveys.